Hello, everyone, and welcome to the Rural Behavioral Health Learning Collaborative. We're pleased to have you join us today. This is Shannon Robshaw with the TA Network, and our featured speakers today are Ginger Meyer with the Clinical Director for Children's Medical and Mental Health Resource Network with the Southern Illinois University School of Medicine, and Matt Buckman, PhD consultant and private practitioner, working with the Trauma-Based Behavioral Health, Opioid Substance Use Disorder Fellowship, and the Southern Illinois Violence Prevention Initiative. So welcome. We appreciate you all joining us today. The key contacts for the Behavioral Health Learning Collaborative and webinar are on your screen. That's Matt, who's newly joining me as a co-lead in this work going forward on behalf of the TA Network today. We're thrilled to have him in that role. And myself, Shannon Robshaw, and then Sarah Warner. So we would appreciate any feedback that you would have directly to us through email or any suggestions for future webinars or topics. We would welcome those as well. We do ask you to stay on the phone, on the line following the webinar and complete a very brief survey to let us know the impact and whether you felt like this was helpful information. We really do want to get some feedback from you, so would appreciate you taking just the few minutes it would require to fill in that survey. Also, by signing up and registering for this webinar, you have been added to the Rural Behavioral Health listserv. And in that listserv, you will receive the PowerPoint, the presentation PDF copy of the PowerPoint presentation, as well as a link to the recording whenever it becomes available. And you will also receive any other resources or information distributed through that listserv for the Rural Behavioral Health Collaborative. If you don't wish to receive these emails and be on that listserv, please just email any of the three of us and let us know that, and we will remove you. But other than that, you will be automatically added. We meet every other month via webinar on a variety of topics. So our next, and it's usually the first Friday of the month. So our next meeting will be in May, on the first Friday in May, and so that will be advertised in the TA Telegram, and so you'll be able to keep up with what's coming then. So we'd like to start with getting a handle on who we're speaking with today. So we would like to conduct this poll to try to get a handle on and understand what organization you're affiliated with. So if you don't mind taking this poll and letting us know who we have with us today. Lots of private providers. Well, what lot? Meaning 32%, only one person. So y'all would just take a minute and kind of click through so we get a sense. We have just about 3 or 4 people so far that have responded. So if we could encourage the rest of y'all to just click on what seems to fit best with your organization, we'd appreciate that. Really would like to understand who we're talking with so we can sort of target the messaging a little bit more and make sure we address what we think might be some interest from your varying perspectives. Well, we've only had 4 people respond. Anyone else want to weigh in? 2 people from education, just 1 mental health agency, 1 Medicaid agency, 1 private provider, anybody else? All right, Tiara, I think we'll just move to the next poll, see if people want to talk a little bit more about their roles in their organizations. We invite you to let us know your role so we can better understand, again, what your perspective might be with this topic and tailoring some information for you. A couple of TA providers. SAMHSA Grant Director. Who else is on the line? You can still answer this poll, even if you didn't answer the last one. Would encourage you to do that. Anyone else want to weigh in? Let us know who's on the line. Anyone else? All right, then. All right, I think we'll just go ahead and move forward then with the presentation. Again, we're really happy to have Ginger and Matt with us today to talk a little more about, to tell us their efforts around workforce development in rural areas. So I'm going to turn it over, Matt, if you want to take it from here and introduce Ginger and introduce the content, and we can go ahead and get started.
Yeah, thank you very much, Shannon, and I look forward to working with this Learning Collaborative more. I appreciate the opportunity to be a part of this group. What I'd like to do is to give just a little introduction, and I'll let Ginger talk more about herself and what her role is and what all she's been involved in. But I feel like she's done an amazing job in Southern Illinois around trauma-informed and responsive workforce development, which is why we've asked her to come and present some of this information, some unique work in building the capacity of both professionals and paraprofessionals based on, the demands of the workforce there and some of the struggles in getting certain types of workforce in the region. I think she specifically has and will talk about the partnerships that have been developed between the university and other system partners to be able to meet the demands and meet the needs in creative ways. Without further ado, I introduce Ginger Meyer and look forward to the presentation.
Thank you, Matt. It's an honor and a privilege to be here to speak about one thing that I'm passionate about is building the workforce and thinking about trauma-informed systems of care and in the rural area and how we've been able to collaborate and leverage many partnerships to do that. We're going to go over today just some information about Southern Illinois and our rural locations. So if you're on the phone and have a rural location, we may have some of the issues and challenges that we have as well. We have also a community-driven approach. I'll talk a lot about that. And I also want to highlight a couple of the successful projects, programs, and networks we have created, followed by the benefits, challenges, risks, and lesson learned. As far as what I do, I'm the clinical director for Children's Medical and Mental Health Resource Network. We are a program of SIU School of Medicine. We serve the southern 45 counties of Illinois, and we are a university program, but it's a community-driven project, so it's a very unique way to come to the university as far as programming goes. We work with over 100 agencies and organizations. Primarily, we see children who have experienced child maltreatment. And so when we were looking at building this mental health network or behavioral health network, we had in mind children and families that experience toxic stress and adversity and the challenges of providing those services when we had very few evidence-based practices that were trained upon in our mental health providers to provide services. And so we're going to look at that today, the benefits, the challenges, and the risks. One of the things that I do is I'm the project director for the Trauma-Based Behavioral Health Fellowship, which is a workforce development HRSA grant at the university, as well as the supplemental grant focused on opioid use disorder and substance use disorder. So I'll touch a little bit on that as well. And then the Garrett Lee Smith Suicide Prevention Program at the university, I am the project director for that, which all connects and ties into the work that we are doing. And then I work with Matt on a number of other projects and things that are in the works. So for Southern Illinois, we are mostly rural counties in our area. We are about 5 or 6 hours south of Chicago, so that can give you an idea of the landscape we cover. We have few transportation resources in our area, no mass transit, and sometimes our families find it difficult to get around. We have limited resources in several of our counties when we look at hospitals, behavioral health, and evidence-based trauma-trained therapists. We have high poverty rates in some of our areas, as well as high unemployment rates, child abuse rates, and high substance use disorder rates, which is why we were able to secure the funding for our supplemental grant focused on substance use disorder in a rural area. Our closest children's hospital, depending on where you live in that southern part of our state, is 1 to 3 hours away in most counties. And in southern Illinois, in the southern 7 counties, we have 4 stoplights, no Starbucks, and 2 Walgreens. So that kind of gives you an idea of the area that I'm talking about. This is the southern part of the state of Illinois, and we're considered the Shawnee National Forest, which I want to tell you, it's a beautiful landscape. So I wanted to give you an idea of some of the pictures that come out of southern Illinois. Gorgeous self-care can happen here. So to give you a picture of how we started developing, in early 2013, Children's Medical and Mental Health Resource Network decided to kind of, survey what we already knew. We knew that we had very few mental health or behavioral health providers in our area that were trained in evidence-based treatment interventions. So in February 2013, we joined the Southern Illinois Behavioral Health Coalition, which is a program of the Center for Rural Health and Social Service Development, which is housed in SIU School of Medicine. And this coalition is consisting of integrated service providers such as our rural health FQHCs, federally qualified health centers, as well as community mental health agencies. I believe there are some schools that attend and others. And so this is the group that we were really targeting on to really get a fair assessment of how many providers do we have, what types of services do we have, and how can we increase those services in working together. So the coalition at the very first meeting requested that I do a training on the trauma-informed treatments just to see, what people were doing. So on July 25th, which was a few months later, we did an introduction to trauma-focused evidence-based interventions working with children, adolescents in diverse settings. We had an overwhelming number of participants, 65 people from various disciplines, so it was multi-platform in nature, which was very nice because we really wanted to get the various sectors involved in how we built this. In the morning session of that training, we had a panel of behavioral health providers trained in evidence-based practices. They gave an overview of what they were doing. And by trained, I mean nobody was certified in the treatment that they were providing, but they had maybe attended a training or learned some of the information and was able to provide that to their clients. During the afternoon session, a focus group was conducted to inquire as to the evidence-based trauma interventions that were most needed for the children, and we focused on the southern 23 counties of Illinois. The results of the work group, the training needs that they felt like their providers or the people as providers needed were trauma-focused cognitive behavioral therapy, which was overwhelmingly number 1, which did not surprise me since it's the most efficacious as well as easy to train on, and the providers were able to say that they had heard of the training. Secondly, parent-child interactive therapy, and third, the Sparks training. So from that meeting, which is where I met Dr. Matt Buckman on the phone, we created an advisory board of the interested professionals from that meeting, as well as gathering additional professionals. At the time, I had an intern who was also very interested in this work, and she was able to go out and talk about the work that we wanted to do to create some of this network and a learning collaborative would come out of it. So we created this advisory board from various sectors and gained support from various stakeholders regarding the initiatives to increase that training opportunity. From here, the intern, she created a database of providers who were interested in trauma training. And as an advisory board, we created a charter to be able to move forward some of the work in a very focused way. So our vision was to improve the mental health of children, adolescents, and families within Southern Illinois. Our mission to be a strong network to promote the availability and quality of mental health services for children, and I'll throw families in there as well, and to develop a strong network of therapist organizations who are committed to evidence-based practices and practice-based research. Some of our goals that came out of that were to increase the number of trauma-informed care organizations and actively providing services to children, youth, and families, to successfully develop and implement a learning collaborative which offers high-quality training in Southern Illinois. And we wanted to really look at the TFCBT, Trauma-Focused Cognitive Behavioral Therapy, or Parent-Child Interactive Therapy, or SPARCS, and use that as a platform since that was what the focus group discussed. And then to facilitate the use of consistent evidence-based practices through mental health organizations in Southern Illinois. To increase the clinical training to graduate students, one of the things that we discussed as a group is, although we do have Southern Illinois University, we have the School of Social Work, which has students who are focused on clinical work, but maybe didn't have the skills and knowledge needed to serve a population that has so much adversity. We also have a rehab counseling institute that also has clinicians that come out of it, but the amount of information that they were receiving about trauma-informed and evidence-based practices was less than we had liked to see. And we also have a counseling program as well. So we were looking at increasing the knowledge, skills, and values of those students. And finally, to develop a network of trauma-informed mental health providers and a way to identify them so that if, we had someone needing to make a referral, we would be able to know exactly who in their area not only provided a type of evidence-based intervention, but also how to make that referral and if they took insurance or the medical card and all of those things. That is still a work in progress through a web-based platform that we're working on. So I'm not going to speak to that today, but I will speak to the other two initiatives. So the three initiatives that we chose to focus on were developing a system of care learning collaborative using those trauma-informed interventions. Developing a training for the up-and-coming workforce and graduate students was kind of our key thought that we would do that. And thirdly, create a way to identify and search trauma-trained mental health providers, sort of a database in this 23-county service area. The first thing I would like to talk about is developing a training curriculum for the up-and-coming workforce and graduate students. In April 2014, we were able to team up with SIU School of Social Work and Dr. Drew Mukherjee, who is an evaluator on our team and a research associate from Texas now, but he formerly worked at SIU when this was created. And we wrote a behavioral health workforce grant through HRSA. The grant focused on creating a clinical-based curriculum for graduate students which focused on trauma and trauma-informed interventions, as well as just the foundational information about trauma, adverse childhood experiences, the neurobiology behind trauma. Each session focused on evidence-based practices and how to treat children, adolescents, and transitioning youth. And each of the students, which we called fellows, would have a practicum that would be clinical and allow them to put into practice the skills learned during those training sessions. So we had both didactic and experiential learning going on in a platform that we also had community behavioral trainers that would come in. Each fellow would present a clinical case presentation to their class or cohort. Their field supervisor out in the field would also come into that session and listen to the clinical presentation. And then we have a core grant team consisting of community professionals all over Southern Illinois who has expertise in whatever the training module that we would have. They would actually be the community professional who would train on the training module. And then each fellow would earn a $10,000 stipend in addition to the knowledge, skills, and values, and the network that they created is amazing. Over the 3-year grant period, 77 MSW students graduated with a Trauma-Based Behavioral Health Fellowship Certificate. It increased their clinical skills and knowledge. 2 of our fellows became TFCBT certified through our Professional Learning Collaborative, which I'll speak about in a little bit. Employment demand skyrocketed. I still get calls every day about who went through the program, who would indeed be a good fit or a good match for the agency or organization. And we had confident graduates because of this, enriched and meshed learning platform that included LCSWs, LCPCs, clinical psychologists, medical doctors, as well as others working in the field with expertise. In June 2014, we rewrote the grant to accommodate the changes in the NOFO. And in October 17th, we received the Workforce Development Grant for an additional 4 years. And we had some changes in the grant proposal itself. We also were able this time to include across the lifespan rather than just adolescents, youth, and transitioning youth. We were also able to bring in those fellow supervisors to be able to be trained in the same modules that the students were trained in. And we were able to provide CEUs, continuing education units, for those field supervisors who attended, which was a big draw for some of them for, free training, great training, and CEUs. And we also focused more on integrating that medical and mental health platform so that, we had the medical piece and the mental health piece more integrated. And then also we added an evaluation component about adversity through adverse childhood experiences and resiliency scores for the fellows. We were also able to write for a supplemental opioid and substance use grant at this time. In 2017 and 18, we partnered with 3 federally qualified health centers. They are located within the 23-county service area I mentioned. And we wrote for increased funding to provide additional training in the area of opioid use disorder, other substance use disorder, and how to use, in tandem with the behavioral health elements, the medically assisted treatment. Our students would provide the behavioral health component in tandem with their medical teams, which has worked out beautifully. We've been able to really encourage them to have team meetings, team chats with a medical physician, and our students are able to talk about the behavioral health component of the substance use disorder in a way that makes most sense to the client and to the patient, and we're increasing behavioral health services, as we know many times is a root cause for the substance use disorder. We're creating a training manual for that so that we can be consistent across Southern Illinois in the training that's provided to our students and the medical teams. So this funding funded an additional 10 students who we call OSUDS fellows, other substance use disorder students. In the fall, these students and their medical teams came to the Trauma-Based Behavioral Health Fellowship, and together the entire group, consisting of about 54 people, trained together on the first 16 4-hour training modules on the foundation of trauma-informed care models. So that included toxic stress, adversity, neurobiology, and then different evidence-based practices that would be used within the substance use disorder programs. Because we are such a rural area, we also don't just have standalone clinics for substance use disorder. So the 10 OSUDS fellows are not only learning medically assisted treatment protocols and the behavioral health that can follow that, we're also talking about chronic diseases as well. One of the other things that came out of that initiative with the training curriculum is the use of our interns and practicum students to be able to have added value to the medical teams and behavioral health and community behavioral health facilities. That use of those students really helped to assist those organizations and agencies to have an increased level of direct service and direct patient care that really not only benefited the student for the educational component, but it benefited the agencies and organizations. And they know the level of students we're able to turn out so that the employment opportunities for our graduating students really skyrocketed once they had these knowledge, skills, and values. So I want to turn to the second initiative that we're going to discuss, which is developing a system of care learning collaborative using the trauma-informed interventions, and how we were able to get there, because the ideas and information was not really decided on in a vacuum. It was a large number of people coming together to decide on how we were going to move forward with our professional development. So we wanted to create a trauma-informed system of care so that a child's community, they're educated about the impact of trauma, when and how to intervene directly in trauma-sensitive manner, assure that all children families will have access to timely, quality, and effective trauma-focused interventions. The way that our communities are structured, some counties have a large number of behavioral health options, and in some counties there are zero or very few options. So it is our thought that we would develop all of these projects within the region so that no matter where you live in Southern Illinois, you would have access to really great treatment. Also, a case planning process that supports resilience and long-term healing and recovery was in our plan. In the early phases of deciding what kind of learning collaborative we wanted to conduct, we identified the evidence-based practice by engaging our community partners, consumers, and key stakeholders. We looked at the fit, the different types of clients, staff, and organization. We made an outline of the implementation process because we wanted to begin with the end in mind and understand what the clinical competency needed to be for the organizational capacity as well. Because we have very few master's level clinicians in our area, we did run into a problem with the bachelor's level counselors being able to enter into our learning collaborative. So that was one of the issues we had to figure out and work out and establish that plan for implementation, quality assurance, and sustainability. So when we did our state numbers, you see 2 stars there, and each represents the TFCBT providers in our area at the time we decided to do a learning collaborative in TFCBT. So one of those providers was Dr. Matt Buckman, and the other was at Centerstone, which is a community mental health agency. So when we looked at this large area that we have, we really needed to up our game with our TFCBT providers. And how did we do that? So we looked at a 4-tier training module that consisted of training for 4 different sectors. Our senior leaders or key decision makers within the organizations. Brokers of service, now these are the people that make referrals to the behavioral health clinicians. These are your advocates, your caseworkers, case management, people that make the referrals, but also are a partner in keeping our clients in treatment, because we could reach out to those brokers of service and say, our child hasn't been to the clinic lately. We were working on the trauma narrative piece. I think that this is what happened. Can you call and check on them? I've left them a few messages. And that really helped to not only sell the trauma-based intervention, trauma-focused cognitive behavioral therapy to the family, it also helped to retain them into services. So we saw our brokers of service as key partners when looking at this learning collaborative. We also looked at clinicians. We were able to train 65 clinicians in the TFCBT learning collaborative, and then we wanted to make sure that the supervisors would be trained in what they were supervising at each of our sites. The participants were selected in each region or county location. However, they sought their teams to be formed. So we had 6 participants in each team, and it looked like this. We had 1 senior leader, or the decision maker of the team, 1 administrator, 2 brokers of service, and 2 clinicians. Each team would turn in an application, and this is just how we decided to do it. We had 19 teams in over 23 counties and 125 participants in the Learning Collaborative. 64 master's level clinicians were split into clinicians and supervisors. Many of the supervisors went on to get the certification. 42 brokers and 19 senior leaders. So I just wanted to kind of celebrate some of our accomplishments on this webinar so you can see how this ended up. The outcomes. So we had 46 master's level clinicians complete the clinical track. 32 were on track for rostering and certification. Out of those, 17 were rostered in TFCBT and have met all of the requirements for national certification. And out of those, 5 are now nationally certified. In 2014, the National Trauma-Focused Cognitive Behavioral Database only had 10 clinicians from Illinois and 0 from Southern Illinois. And today, the database includes 23, and 5 of those are from our Trauma-Informed System of Care Learning Collaborative. 22% of the state of Illinois TFCBT nationally certified trainers are now from Southern Illinois, which we feel like is a really major accomplishment over an 18-month period. So as you remember, we had 2 clinicians, and now it looks like this. So you can see regionally, we were able to diversify where those TFCBT clinicians were, and we have some work to do yet. And we will continue on with learning collaboratives with the partnerships that we have built. But we are very excited to be able to provide those services to families. The project that we did was nominated for 2 SAMHSA awards, and we won in those categories that are below. We won the Gold Award. The first in audio professionals. We were also in partnership development. And the Trauma-Informed System of Care Learning Collaborative partnered with over 40 different agencies and programs to train all that were involved. And in all, there were 125 participants that were in 23 counties, which is a big deal for those 125 people to travel, to do the training, and to participate in the 18-month collaborative. Here we are, and the hands on the 3 canvases represent the number of children we were able to serve within the time frame of this TFCBT 18-month learning collaborative. And you can see that we served over 200 children, and the outcomes were just amazing. So how would we fund something like this? Our funding sources, grants, private donors, foundations, corporations, agency training dollars, and other grant projects that kind of weaved into. So we had a very blended way to fund this. This represents the Bouchard Foundation for Abused Children. When I went to speak to them about funding a learning collaborative, they were very excited. I was going to meekly ask for like $5,000, which I've learned never ask and let them tell you what they're going to give you, because I left that day with $100,000 that they were going to fund. And so this is a picture of myself and the Bouchards with a check that they donated to the Learning Collaborative. We also were able to receive $80,000 out of a Rural Health Initiative grant in partnership with SIU Rural Health Initiative partners, which was nice because that helped some of the infrastructure funding for the Learning Collaborative. Some of the benefits for a community-driven university-based partnership: the university provides a large county outreach. They have the administrative structure for applying for funding, professional development credits. The university has several departments willing to participate in community partnerships. There's an increased capacity for direct services. It's a multi-learning platform for existing workforce needed to current training and students in practicing the didactic and training in the field, as well as that experience that they have. The university can serve as an anchor for a project or program, and I think that when that happens, you don't have as much competition, and you might not have as much, well, this particular organization or agency is leading, so we need to look to them. The university kind of helps bring all of those organizations together. And it's also a large employer in our region, and so it's seen as, something that's an anchor. Some of the challenges or risks can include the university moves slow on new ideas, services, and grants. We've had to help them speed things up or try to figure out how, under a policy or procedure, we can make things happen. Universities have policies that can get in the way of forward planning due to some of the structure and approval process and the legal departments that have to get involved with such things as contracting with other service providers to provide training. But over time, we've been able to simplify those things and have templates for those things. So although there was a lot of work going into that, it was well worth it. Sometimes contracts can take too long or stall in the process, and we just have to keep driving that. Some of the benefits for the university: the community partners know firsthand what the workforce development and employment needs are. The university gains a view on the strengths and needs of each community partner and synergetic energy that occurs within the region, being on the same system of care mindset, which is really the driving force for some of this snowball effect that's happening now. The university will be able to employ newly graduate students within the region very quickly. Some of our current fellows right now have jobs where they're doing their internship that they were hired during that period of time, or they have jobs waiting for them. Some of the challenges or risks: the community partners may decide to bypass the university system due to strict policy guidelines on funding and contracts and process. Sharing successes sometimes is difficult for a large organization because, taking credit or getting that press or publicity is important. And then potentially partnering with entities that may be seen as competition can be a challenge. Other projects that we're currently working on: Resilient Southern Illinois, which includes 17 school districts, talking about trauma-informed schools. That project is moving along quite nicely. Building a Compassionate Community Trauma-Informed System of Care grant. It's an Illinois Children's Healthcare Foundation grant given to 5 counties in Southern Illinois. And the driving force, again, is that trauma-informed schools, working in multiple agencies to get rid of that silo effect, to try to figure out how we can communicate with one another And this is a planning grant, and as soon as the plan is turned in, it's anticipated that there will be more funding for implementation. We're very excited about that. Providing training and technical assistance in evidence-based practices throughout our region. We have several other trainings that are on the schedule, and we are able to pull not only from our master's level graduate students, but other professionals that are ready for this training and excited about it. And then laying the groundwork to start a center focused on workforce development using trauma-informed systems of care models, that both didactic and experiential training using simulation and providing direct behavioral health interventions to families. So those are some of the things that we're working on. Some of the lessons learned, the key to collaboration is trusting relationships. It's really important to build on those relationships and have that trust, especially when we have few resources. I oftentimes travel to Chicago, and they are so surprised that the way that we're able to make those partnerships and connections and collaborations. But when you don't have as many resources, you have to work together to be able to bring those resources to our area. When all the partners lay aside who gets credit, it's a win-win for all. Resource sharing happens, and it happens very freely. There's a synergy in thoughts, ideas, funding, and this excitement occurs, which creates additional opportunities, and we've seen that time and time again with the projects that we have. Planning for the region attracts additional partners who want to join the effort. Students graduate having built a network of professionals and an intimate knowledge of community for which most of them will be employed. They hit the ground running and ready to work. And the number of trained providers within the system of care is increased, which increases capacity for all the direct services provided. So with that, that is the information I brought to share, and I will entertain any questions that may be out there.
Thank you so much, Ginger. That was just fascinating. I'd invite anyone that has questions to please type them in the chat box, and we would be happy to take those questions and respond to any inquiries that you have. I'd be interested, Ginger, if someone on the line, not affiliated with the university, but someone more in a provider setting wanted to initiate something like this in their local community, how would you recommend they go about getting organized? Should they organize a network first and then approach a university, or approach the university initially, or any suggestions for how to start something like this in a new community?
Sure. I think what we did first initially is gathered like minds and really put out there, kind of a sense of a vision of what we wanted to do. And when you go to a university with a plan and a strategy, they seem to really, glom onto that more so than if you say, hey, we have this idea, we're not sure how to do it, unless you find, a very direct person that can kind of help guide you through that. I would definitely create that synergistic, this is what we want to do, gather everybody, and then take it to a point person at the university that will help to cut down some of the red tape and bureaucracy that happens whenever you first, initiate something like this.
Okay, that's good. That's good guidance. And you're affiliated with the School of Medicine, but I'm assuming you could approaching the School of Social Work. There could be any number of departments that would be potential partners.
Yes, absolutely. And, we have the Center for Rural Health and Social Service Development, which is an amazing entity. So if you have something like that, or policy making type of department, many times they're very interested in community-based programs, and so I think that might be an entrance point. Both myself, with my appointment, I'm within the School of Medicine, and so is the Center for Rural Health and Social Service Development, so that made sense that we went through the School of Medicine, but absolutely you could, look at any of those departments that are more community partnership oriented.
Great. Well, any other questions from participants before we shift to the next presentation? We'll also have opportunity at the end after Matt concludes his presentation to take any remaining questions. So I think we'll move on. Thank you again so much, Ginger. That was really fascinating. Matt, I'd like to turn it over to you.
Certainly, yes. Thank you, Ginger, for providing that presentation and really highlighting the strengths of university and community partnerships and having universities as system partners and how that collaboration can be beneficial both directions. I know a lot of universities in rural areas and other areas, they're looking for partnerships and just finding a way to be able to be like-minded and work together is something that everyone is usually looking to do, although it's a lot easier said than done. So thank you for providing that information. A little bit about myself. So from a rural area, a town of about 500 people. My father was he's a retired coal miner, and one of the things that he told us was that we could do anything that we wanted as long as we weren't coal miners. And so my family, we were kind of posed with that and looking for ways to basically be taught to get out of the community and finding that there's, something really amazing about the community aspect of our smaller areas and how we all band together and work together to be able to accomplish so much. I think systems of care have a lot of traction in these community-focused areas. What I would like to focus on and talk about is managing and adaptive practices or adapting practices and the concepts around that. So specifically on common elements behind evidence-based practices or just to improve the quality of services that are provided. If your area is similar to mine, in this, what I find is that there's never enough workforce, there's never enough quality in the workforce and their preparedness for the work that we're doing in our systems of care, and that is in multiple sectors, not just in behavioral health, but we find that in child welfare, we find that in the justice system and the education system, that preparedness is a challenge. And so I love how Ginger talked about this collaboration, because then the preparedness for the actual work that that we're trying to do in our system of care is starting at the university level versus that being a disconnect, and then how I can support the universities in their work as well. So with limited preparedness, turnover is a pretty big challenge. Having the right qualifications for certain types of quality or evidence-based practices, that's always a challenge in my area. And then how to balance, the training versus service time, in that I find myself the onboarding process being a heavy load to lift, and then there's just never enough time. There's always high demand for services, and I don't see our work becoming less relevant in the future, or that we're going to find less individuals or having behavioral health needs or challenges. And so with this work that we're all undertaking, there's never enough time, and there's always a strive to improve the quality of the work. So I found managing and adapting practices as a tool that actually statewide, the state of Illinois actually purchases this, or at least certain tools statewide, and didn't quite have the same training availabilities, but I've been fortunate enough to be able to work with this company, and it bases its work on the common elements of effective practices, which I'll talk a little bit about. But in this, I want to be able to take this understanding of common elements and the current research out there, and how you can take the concepts and practices And this is one set of tools, but it's not necessarily the set of tools, you know, because you can create some of these things. You probably already have some of these tools that exist in your systems or in your state agencies that are available, or maybe it's already in your EHR systems or whatever kind of system that you're using. And so you don't necessarily have to have this set of tools, but I want to pull from the concepts of this. I've been fortunate in that in my experience, and I'm a clinical psychologist and have traveled a little bit for different training opportunities, and have had the fortune to be able to become trained in several evidence-based practices and to become a trainer and supervisor in some of those as well, so that I can then enhance or support workforce development. However, what ends up happening is that I can never be trained in enough. And in our rural areas, it's really hard to have our specializations, whereas as Ginger's talking about trauma-focused CBT and trauma-focused treatments, you just talk about PCIT and Sparks, in that it's very challenging to be able to have that specialization, that you have someone that's trained in TFCBT and that they can primarily practice trauma-focused treatments with that specialization in our rural areas. And so then we find, or I find, that few individuals, supervisors, directors, or trainers within our systems of care are having to carry the weight of multiple evidence-based practices. And it's really hard to be able to have and effectively implement multiple practices at the same time, when some are complementary and some may be a little bit different than each other, but still effective. So a couple of things that I want to just kind of pose for consideration is that there's 972 randomized controlled trials for treatments of youth mental health. So we want those to be able to inform our decisions and to be able to infuse that understanding, that research into the quality of what we do. Now, they've tested this 2,300 times in different studies for the effectiveness of that. And then out of that, there's 689, so about 700 evidence-based protocols or evidence-based manualized treatments. That in that, there's 700. So if I want to be the most effective practitioner, now some of those are going to overlap with each other, but to do so, I almost have to be trained in hundreds of different evidence-based practices. So instead, the majority of our youth that are receiving services, they still do not receive care that they need. So there's a good chunk of folks that are not accessing our systems of care, that maybe don't feel welcome in that. There's a good amount of our practitioners, our providers, our clinicians that don't feel comfortable and don't feel effective in the practices that they're doing. And that becomes quite a bit of a challenge in that we are leaving this gap in services. And then some of the research, I think maybe Leonard Buckman had done this work, but some of the research, I think it's around 80% of all treatment that is provided is, even though folks may have been trained in something, it's not necessarily a quality practice or an evidence-based practice. So only around 20% of those who are getting treatment are actually getting one of these effective practices as we've determined those to be. Now, evidence-based practices is also a little bit of a buzzword at this particular point. However, there's quality that usually we're all striving towards, and the reason why we want to be able to grow evidence-based practices and implement quality services, because we want to address the need of the 1 billion people in our world that has a mental health need. We have huge amounts of needs, with 1 out of every 5 children that are going to demonstrate a diagnosable mental health disorder. And the fact that we will never have sufficient workforce to meet these needs, and that providers are always going to be forced to be a little bit uncomfortable or to push themselves to be able to provide services that they haven't had extensive training on, or that they haven't had the privilege or the opportunity because of limited resources or funding because of their qualifications. One of the things that we find in my region is that a lot of paraprofessionals, a lot of folks that don't have advanced degrees that may be required for certain evidence-based practices, they're not eligible to participate in the training programs, yet they may be the ones that are providing the majority of these treatments. So this type of gap between the two makes it where almost where the youth and the families don't have the same opportunities in areas that workforce looks the way that mine does. So our goals are still not happening. So our ability to be able to reach that, all of the research that's being conducted and lots of support and hard workers and effort that's being exhausted to be able to identify these things work. This is effective. There's about 11-year difference between or gap between when research is published to whenever it's actually used or implemented in the field or realized in the field. And so we want to be able to close that gap. And we want to be able to have where evidence-based therapies and treatments that evidence can be utilized in our practices that are there. So what do we know about EBTs or evidence-based therapies or treatments? That some of the bundles, some of the practices that are there, there's few youth that are sometimes eligible because in my setting or in our world, the complexity of cases many times would have been excluded from inclusion into the trial or the research for that, because it's not uncommon for me to have someone that both meets criteria for ADHD and anxiety, whereas most of the treatment research will have focused on anxiety only or on ADHD only. And so that makes it more complicated of now I need not only a treatment that is for anxiety and ADHD, but now I need a treatment for an individual that has both anxiety and ADHD. And so some of that disconnect between practice and research is there. So how do we translate this for our providers, for our systems, for our partners? And then some evidence-based treatments are not going to be effective. No matter how hard we work with differential diagnosis and trying to identify what is the primary cause of impairment in functioning or risk of out-of-home placement, sometimes the complexity of the case is so much that maybe things aren't working. But we still need to do something with them. Lastly, there's in evidence-based treatments, there's an overemphasis on the general knowledge or on the randomized control trials or general theory versus local knowledge. And what we want to be able to do in our systems is to incorporate and to work towards understanding over time what many of our wisest providers have already learned. And so looking at practitioners who have been working in the region, in your region, in my region for 20 years, those individuals have learned that certain practices work better for certain individuals given the culture, given the region, given the common values. And then the other piece too is family voice. So family voice is very much part of evidence-based treatment. And how do I incorporate that family voice? Well, if someone were to give them a diagnosis of anxiety disorder and then I just did the protocol for anxiety disorder, that's not allowing the family voice. And so how can I understand what type of treatment has an individual experienced in the past, and then how do I make some adaptations to that or take into account what they believe about the world and about others and about themselves and their own struggles, and how can that make me a more effective clinician? Sometimes even maybe the best treatment that might have the most research, it may actually trigger more resistance or disengagement or lack of interest because they've seen that treatment before, or that treatment was the same treatment that was in the hospital, that maybe it needs to be, I need to adjust based on what the family is telling me. So what we want to be able to do is we don't want to just say, throw the baby out with the bathwater. We want to consider what part of the evidence-based treatment literature is available, and how do we take that in more of a complicated way of thinking of what does that tell me about the treatments that I'm providing. So we want to move to a little bit of an a la carte type of approach where we can unpack these many evidence-based practices, which is what the common elements literature has done, and that we've unpacked it to show, what were the common elements across all of those treatments, and then how do I have the flexibility, the adaptability to be able to take in the family voice and allow the youth to guide this treatment in some way or another so that I can really find something that resonates and is effective for that individual versus someone who maybe the research was done 3 or 4 states over. So what we do is we're trying to develop kind of understanding different families of treatment that might be available out there, and then looking at the protocols, and this work has already been done and is available. It's publicly available for folks on now what are the practice elements or the common elements that are under each one of these protocols, and then how do I understand then how effective, like for parent training, timeout can be, or effective commands or attending or time in can be for reducing disruptive behaviors and decreasing conduct type of issues or challenges. So practice-wise is under managing and adapting practices is under the company practice-wise, and that's not necessarily something that you have to utilize. It's just something that is available. And so in that, it takes a lot of this research, and some of you may have different tools that maybe the state or a foundation or your grant has purchased to be able to allow the use of the research to inform your decisions. Many times there's maybe evidence-based registries that are available, but in this particular one, searching by multiple types of issues or focus or foci for the treatment, and then it's going to produce a list of the different approaches that are going to be most effective, such as for, as Ginger was talking about, trauma-focused treatment. So if I search for trauma for a 10-year-old, then what I'm going to see is that 80% of all treatment protocols are going to have psychoeducation for the child. So there's psychoeducation around trauma for that particular case, and then maybe around 70% have exposure or a trauma narrative component to that treatment, and then maybe around 50% have psychoeducation of the caregiver around trauma. And so then I can, not that any of these tools should be telling me what to do, because this is only one piece of the evidence base. I also want to be able to take some historical context, the wisdom of our elders or of our experience that allow us to be able to say, this is kind of what I've seen work with my practice here. And then also the family voice and the youth voice to be able to say, these are the things they've said are working or can work for them or what they're looking for. So it's kind of allows for a meta-analysis and allows us to be able to look at that information, which is, any type of tool that we can get that can be user-friendly and quick enough that clinicians with really busy schedules are able to utilize. We can improve the quality. And then we want to get to, that kind of gives us the idea of what to do. And now what kind of tools might be available for how to do it. And so if I'm doing a specific treatment, so such as trauma-focused CBT or incredible years or PCIT, parent-child interaction therapy, if I'm doing a treatment like that, the manual is going to walk me through basically what most of the sessions are, and I'm able to be manage both fidelity while also being flexible for the family. And manualized treatments or treatment protocols evidence-based treatments are not as strict as what many perceive them to be. So we do have the ability to do both things in this, both manage and stay the course for what's effective, while we also have the ability to adapt or be flexible based on how progress monitoring results are giving us that tells us whether or not something is working or not working. So the Managing and Adapting Practices has developed these practice guides that also provide instruction on how to provide. And it gives you this is a generic type of template that has an expert consensus on these are what the practice would look like, but then allowing a lot of flexibility that from this template or from this particular guide, I can add more, I can adapt the language, I can adapt maybe the level of language that's there or certain types of aspects that the family has given me that tells me that they need this adapted for their needs. So just to break down a little bit about what a practice guide would consist of is just to show, I kind of put out the name of what that is, and there's around 50, 55 practice guides that are available based on, and then you use them based on what type of need there might be in the treatment planning. Talks about when to use that practice guide, and then who's it for. In addition, it's going to walk through kind of a checklist. So as a person becomes more fluid with their ability to be able to complete this treatment or implement this practice, maybe through experience or through training, then they might just use the checklist. And then maybe in the starting portions or until they become more fluid, then we might have more details. And sometimes even scripts are available for providers. And so we're going to find this. There's lots of good resources out there, but this is some of the tools that we find in our experience. We find that our practitioners are needing tools. They're needing resources. They need